Hi, I'm Sherry Hume, and I'm a co-founder of CureJM, and this is the presentation on treatments and side effects. I have the honor to introduce our two speakers today, and we have Dr. Hannah Kim, and she is a pediatric rheumatologist who studied interferon-mediated autoinflammatory disease, novel biomarkers, pharmacokinetics, and pharmacodynamics in a compassionate use study during fellowship at NIAMS and part of the NIH. Currently, as a Lawrence Shulman Scholar, she is focused on studying pathogenesis, including the role of interferon and identifying activity-related biomarkers in juvenile dermatomyositis. Hannah Kim's current research interest is pathogenesis and biomarker discovery utilizing transcriptomic and proteomic analysis in JDM and autoimmune inflammatory myopathy that we're all very familiar with. Particular focus is placed on how this disease compares with Mendelian autoinflammatory diseases, identification of disease activity, related biomarkers, and myositis autoantibody subgroups. The overall goal of this translational research in JDM is to identify more targeted therapies with decreased adverse effects and better monitor disease activity and treatment response. Among Dr. Kim's many professional accomplishments, Dr. Kim is conducting a CureJM-funded research project, Novel Biomarkers Associated with Disease Activity in JDM. This study will compare and contrast serum markers and gene expression patterns in JDM with those of other closely related disorders, which are Candle and Savvy, with the hopes of better understanding the causes of JDM and possible treatments. Lastly, she is also leading a compassionate use study on a JAK inhibitor treatment in JDM, which is very exciting. It's called baricitinib. I think I got that right. Right. Baricitinib. Say it again. Baricitinib. Yeah. Anyway, it's very exciting. Okay. Dr. Curran, I finished. Okay. Now, part two. Dr. Curran. Dr. Megan Curran grew up in suburban Kansas City, attended college at Stanford University. She attended medical school at Michigan State, completed her pediatrics residency at Miami Children's Hospital, and completed her pediatric rheumatology fellowship at UC San Francisco in 2009. She then moved to Chicago, where she was an attending physician in the Division of Rheumatology at Ann and Robert H. Lurie Children's Hospital of Chicago, and an assistant professor at Northwestern University Feinberg School of Medicine. She is now the director of the Pediatric Rheumatology. This is very recent. Sorry. I'm trying to read your line.
Oh, fellowship training program.
Okay.
Children's Hospital of Colorado in Denver.
Okay, yeah. And at the Children's Hospital of Colorado at the University of Colorado, Denver. Okay. Then I'll go to the, okay. Caring for patients with juvenile myositis, sorry about that, is her primary clinical interest, though she sees patients with all rheumatic disease diagnoses. Her academic and research interests reside in curriculum development for resident and fellow education. Her career goal is to increase the quality and quantity of rheumatology and musculoskeletal education offered in pediatric training programs nationwide so primary care providers can recognize patients with rheumatic diseases like JM and refer them quickly to a pediatric rheumatologist. Additionally, she strongly believes that patients should be given the opportunity to participate in clinical research so we can learn more about the pediatric rheumatic diseases. She participates in childhood arthritis and rheumatology research alliances, JM registry, and research projects. Ladies and gentlemen, please help me welcome Dr. Hannah Kim and Dr. Curran. And we're starting out with Megan Curran.
Oh, thank you, everyone. I'm speaking for Hannah, but we really enjoy coming to these conferences and speaking with families. It's always a challenge to understand how to target these talks about treatment. I have a feeling we have people in the audience coming from different places, just people who are learning the very basics about medications. Any hands? People who feel like you have a small understanding of medications. Okay. How about medium understanding? Any fairly expert, like good understanding of meds here? Yeah, a few people who've been around, some medical people here. Okay, so I think I'll just start off, and if we're moving too slow, let us know. And if you have more complex questions, we'll try to translate them for the rest of the audience as well. Does that sound good? I'm going to sit just because it's going to be easier for me to move the slides this way. Can you see me? Okay. So at first, we just wanted to give some acknowledgments to some other doctors who have given similar presentations and allowed us to use some of their slides and modify their slides. Dr. Huber, who's not at the conference this year, he is also highly involved in Cure JM. He's the kind of the president of the JDM group there. Dr. Ardalan, who is here, and Dr. Koja, who was our training fellow at Northwestern. And is going to be continuing to do some research with Dr. Pachman at Northwestern. So the goal for the talk today is to discuss current and future treatment strategies. You actually heard a bit about this morning from really quite expert people, so I might not be able to answer all your questions. We're going to focus on medications, how they work, and some of the side effects. And I'm going to give you like an immune system overview to understand what the medications are targeting. And then I'll talk about steroids, our friend. And then Dr. Kim is going to talk about the other medication. We wanted to leave plenty of time for discussion. So I think each of us are going to talk for maybe 10 minutes or so, 10, 15 minutes, and then we'll open it up for questions. And then just a little plug that we've heard a little bit this morning about other treatments. We're going to focus on meds, but always remembering things we've learned about exercise, physical therapy, sun protection. I don't want to minimize those. So as physicians, we're always supposed to talk about our conflicts of interest if we have, investments or if we're getting paid from a pharmaceutical company and we don't have any conflicts of interest. So the current way that we treat patients with myositis, as a physician, I first look at the patient, figure out the diagnosis, and try to determine as best I can with all the data that I can collect, blood tests, imaging studies, how sick is the patient. And then at this point, what we think is, depending on how severely sick the patient is, we might be more aggressive with treatment. We don't really know if that's the right way to do it. Should every patient get very aggressive treatment? Should we be very gentle with certain manifestations of disease? We're still trying to understand that. But when we do treat initially, we call that induction treatment, like the beginning. And usually that's kind of a bigger burst of medications. And then over time, the medicines that are taken more over time, we call that maintenance treatment. So induction and maintenance. And the way that we think about the diseases we care for in rheumatology and myositis in particular is that it's an overly active immune system. And so there are two ways to treat an immune system that's overly active. So we suppress it or slow down the activity of the immune system, or we can modulate it, meaning kind of changing it in certain ways that might allow the immune system still to function appropriately. When we suppress the immune system, that the danger in that, you all know, is that patients can get sick because they won't be as well protected against infection. So steroids are the mainstay of our induction treatment, and we use steroids because they hit the disease fast and hard. They also have a lot of other side effects because they affect the rest of the body, and we'll talk about that in a minute. And then our kind of mainstay maintenance medication currently is methotrexate. Dr. Reed talked this morning about the study looking at cyclosporin that is used more in Europe versus methotrexate. And we view methotrexate as our maintenance medication. Usually as a subcutaneous injection, we feel it works better that way. Then medications that can modulate the immune system and not necessarily suppress it, but just change it in ways that are helpful. One of those is hydroxychloroquine, which we often refer to as Plaquenil. This is an oral medication that might be helpful for skin rashes. The other big immunomodulatory medicine that we use a lot is IV gamma globulin or IV immunoglobulin, IVIG, which are antibodies from healthy people, and we'll discuss this as well. So Dr. Reed talked a little bit this morning about the consensus treatment plans that were made by this organization called CARRA. And these plans, she said, are an attempt for us to standardize care so we can study things a little bit better. She showed all those colorful graphs of how different rheumatologists wanted to treat differently. So when we standardize treatment, it allows us to compare treatment styles, and it allows us eventually to compare one drug to another. We call that comparative effectiveness research. So Dr. Reed showed the treatment protocols. I'm going to just breeze through these slides. But as part of the treatment protocols, we also came up with a steroid tapering regimen for patients to be on. So all rheumatologists tend to taper steroids a little bit differently. And there's truly not a right or wrong way to do it. But I have to say, we came to a consensus. There's a lot of people arguing in a room about what's the best way to do it. And finally, we had to come to a consensus like, okay, I might not do this myself, but I agree for the sake of consensus that this is a safe and probably effective way to do it, and we're going to do it this way. And we also, like she said, we have the flexibility when we are following these consensus treatment plans, CTPs, to say, no, this patient is not responding the way I want. There's bad side effects, or we're tapering too fast. We have the ability to change that. So this taper goes to about 50 weeks. So it's a 1-year taper of steroids. So let's go back and talk a little bit about the immune system, an overview of the immune system. This is going to make you, I want in your head for you to think you are considering your daughter or son or grandchild as a whole person. And when we think about drugs and how they work, we're going to go down into the most minute details. So imagine like you're a camera and you're zooming down from the whole person down into the blood vessels, into the cells, into the little insides of the cells. This is going to bring you back to high school biology. So one of the problems in myositis, most types of myositis, especially dermatomyositis, is that we have problems where the immune system is attacking on the inside of blood vessels. These are your tiniest capillaries that we look at when we look at your nail folds. And the inside lining of those capillaries are something called endothelial cells. And endothelial cells are a big target for attack of the immune system in this condition. So this is why we call it a vasculopathy, a problem with the blood vessels. And this is a slide to remind me to tell you that the skin can be a window into the vasculature, the blood vessels. So when we're staring at your child's skin, we're trying to get an understanding of what's going on with the blood vessels underneath. Why is the skin red? Why are the blood vessels dilated? Or are they damaged a little bit? This slide is just to have us think about the blood. So when we draw blood from your child, blood will eventually settle out. So we have red blood cells, we have white blood cells, and we have platelets. Those are all part of blood. And when you put it in a tube, the red blood cells settle down at the bottom, and then we get this little layer in the middle of the white blood cells and platelets. And then the plasma is the liquid that everything is dissolved in, and things like antibodies can be floating around in the plasma and stay in there. So that's kind of how we think of blood. So why do we call it dermatomyositis? So dermato means skin, obviously. The skin has blood vessels, and that's what we're seeing when there's redness of the skin. So the blood vessels kind of lay in this layer deeply, and then they reach up, the tiny little capillaries reach up to the top here. So when we're looking at nailfold capillaries, that's actually what we're looking at right there. Myos means muscle. Muscles are made of groups of bundles, and inside the bundles are the fibers, and the fibers are cells of muscle. So we're targeting, the inflammation is happening inside these tiny little fibers. And this is where the drugs need to target. So when you look at a muscle under magnification, this is a normal muscle with those fibers that are evenly sized, and then kind of blood vessels in the middle. And in a patient who has myositis, they get inflammation, which are these more purple cells. Those are white blood cells coming into the muscle itself. And there's a better picture of it up close. So that's a blood vessel there. That's a muscle cell. The other thing that we have to think about in this disease is the itis at the end, or inflammation. So that's the main problem. And when we have inflammation, it's an overactivity of the immune system. So this is a diagram that tells us all about the different cells of the immune system. All of these kind of down here at the end are white blood cells. So when we draw blood and we're looking at the white blood cell count and the different types of white blood cells, these are the things that we're looking at. And you might recognize some of these letters and numbers if your doctor does flow cytometry, looking at NK cells or B cells, things like that. That's how we identify those cells, by these numbers. The other important thing to know is that there are certain type of B cells, white blood cells, lymphocytes, B cells, those are all kind of the same thing, that make antibodies. And antibodies are very targeted and directed, like a lock and a key. They're just targeted to one thing. And in myositis, you hear about myositis-specific antibodies. This is where the immune system has made antibodies that attack your own parts of your own cells. So just think of antibodies. They look like little Ys. That's why we draw them that way. This is a selfie. So as we're kind of narrowing down into the different structures of the body, you probably remember from biology class the structure of a cell. So a cell has a membrane. Inside the cell, there's a nucleus. There's the mighty mitochondria that make the energy for the cell. And inside the center of this cell is where all of these chemical reactions occur to turn on inflammation. So you can think of the chemical reactions of the immune system like accelerators and brakes. So the accelerators we all need, you get a virus, you need accelerators to turn on your white blood cells and make them active. And then we also need brakes to slow them down. So once the virus is taken care of, the brakes come in. And we all have many different pathways that are like accelerators and brakes. And part of the problem in autoimmunity is that some of us have accelerator pathways that just might be a little heavy, or brake pathways that don't work as well. And many of us have these and we're perfectly healthy because there's checks and balances. But if you have enough of a combination, and it's not just one specific thing, it's a combination of multiple pathways, that's what can predispose a patient to this type of autoimmunity. So accelerators and brakes. You've seen some slides today that show you DNA. Remember that the DNA lives in the nucleus of the cell. And when pathways, accelerator or brake pathways are turned on, it actually gets into the nucleus of the cell and the DNA is made that turns on accelerators and brakes. The other thing to think about inside the cells are signaling pathways. So these various pathways that are accelerator pathways and brake pathways, and we're going to talk about this a little bit more, but you might have heard of some of these newer medicines like baricitinib that Dr. Kim is going to talk about. It affects one particular pathway that has, the pathways have all of these little chemical reactions in them, and these are all proteins, these little structures. And the medicines that we have today are now able to target these proteins in particular that are acting inappropriately. So you don't have to learn these things, but this is just kind of the idea for you to think about when a doctor is giving you a drug, what's actually going on, where is it targeting? We know that in myositis there are various pathways that are overactivated that we need to turn down. And one of the medicines that we use are steroids. So Dr. Nagaraju talked today about this new formulation of steroid called vamorolone. And he talked about how certain aspects of the steroids give you lots of side effects and other aspects of steroids do not. I'm not going to go through these. So just remembering the different pathways that we're going to be treating. Okay, so I'm going to talk for a few more minutes about steroids. How many people in this room have a child or relation who has been treated with steroids? Every single person? How come you don't? You're a researcher. Okay. All right. I've taken steroids for asthma. Fortunately, short courses of steroids don't tend to have many, many side effects. I can tell you, I don't have a child with JM. I take care of a lot of kids, but I did have a cat who had cancer, and my poor cat had to get steroids. Every morning, the cat was banging down the door in the bedroom. I'm hungry. I want to eat right now. Meowing, waking me up. I'm like, oh my God, these poor parents. How do they deal with this? It was a challenge. Steroids are like the Incredible Hulk. My cat turned into the Hulk, the feline version of the Hulk. Steroids work very powerfully. So this is, like I said, why we use them in the beginning. We all make steroids naturally, so cortisol or corticosteroids, you've heard that word, they have a lot of actions in the body that are appropriate and necessary and helpful for vital functions. So all of these different areas of the body, they have effects in your brain health tissue. It's an endocrine tissue function. Metabolism, meaning where body fat is distributed, how proteins are broken down and turned over, how muscle cells function, and then of course inflammation. Steroids tend to turn down the immune system. That's why we use them in high doses for this. But they also support vital functions. One of the main reasons that our body uses steroids are for this kind of fight or flight reaction. If there's stress in the body, we get a big burst of steroids to help our body manage it. And after we take steroids, our adrenal glands, which make natural steroids, they go to sleep. This is called adrenal suppression, and they take a very long time to wake up. So this is one of the reasons why we taper steroids very slowly over time. So for JM, we heard today about back in the 50s or 60s how before we had steroids, many patients died because they weren't able, the immune system, the overactivity of the immune system caused so many severe problems. In the late 90s, in the 90s is when we really started to use steroids IV in doses that are strong enough to go into the middle, that nucleus of the cell, and to shut down some of those pathways like this NF-κB pathway that are overly active. Pathways make, within the pathway, the immune system is making these chemicals that are called cytokines. That's another word that you might hear. Cytokines or chemokines are these little protein messengers that float around in the body and tell the immune system to turn on or off. They're like carrier pigeons that are saying, turn on, turn on. So that's another place that we're able to target with our drugs. So IV Solu-Medrol, there was a study done in the late 90s that showed that patients tended to have quite a few side effects to IV steroids and oral steroids as well. We also found in a study that done at my center at Northwestern with Dr. Pachman that patients who got more IV steroids tend to respond earlier than patients who were treated just with oral steroids, but it did increase the cost of treatment. And we have also learned how IV steroids work a little bit differently than oral steroids. And then in the 2010s, we had more guidance through the CARRA protocols. So one thing to think about in juvenile myositis is that we have this little window into the blood vessels when we look at your nail folds. And this is normal. You don't see many blood vessels here. This is a patient who has dilated vessels that are a little bit widened and irregular, and then this is a patient who has areas where blood vessels are very dilated, and then some of them have actually died away. And that's a way that we can look on a bigger level to understand what's going on with the nail folds. So interestingly, when we use steroids in higher doses, we can, this picture just basically tells us that when you use the steroids in higher doses, you get more absorption into the body. When those little capillaries are damaged, they don't allow you to absorb the medicine into your body as well. So you can think those little capillaries we have in our fingers, but we also have them in our gut to absorb the medicine that you're swallowing. But when you put medicine directly into the blood vessel, it doesn't have to go through those blood vessels to be absorbed. It's just in there. And that's one of the reasons that we'll use IV steroids in the beginning. So patients who have more damage of their nail folds tells us that they might not absorb the medication as well because those little blood vessels are not working as well. I'm going to skip these. So let's move to steroid side effects. Everyone here knows about all of the different side effects that steroids have on the body. And the way that I like to think about them, and when I discuss with families, you can kind of characterize some of these side effects as dangerous, like very dangerous. Those are the red flags. Steroid side effects that can be permanent, ones that can be reversible when the steroids are taken off over time. those that are definitely going to happen to anyone who takes steroids. And then there are some that are more rare and they don't happen to everyone. So when you see this giant list, all of these things are not going to happen to you or your child. And some of them are quite rare. For all of these side effects that are possible with steroids, we have certain ways to mitigate or help the side effects not be as bad. So, for example, when patients take steroids, they can irritate the lining of the stomach. And this is one of the reasons that we give medicines that protect the stomach from too much acid, so the lining of the stomach doesn't get irritated from the acid. Steroids also cause bone loss, so that's one of the reasons that we give calcium and vitamin D to help build bones. We can come back to this slide later if people have specific questions about certain steroid side effects, and you're welcome to take a picture of it if you want. So these medicines that we use to help treat the side effects, there are other things that can be done besides medicine, like taking prednisone in the morning with food, making sure a healthy diet is eaten because of the side effects that steroids have on hunger, and the way that they make you hold on to calories. The other thing that a family told me one time that I thought was an important message to pass on is that, my child gets so angry and upset, the fuse is shorter, tears come much more easily. Recognizing that this is not my child, this is actually the steroids, that this is something that is not inherent to my child, and this is something that will get better over time. As patients gain weight from steroids, they can also develop high blood sugars or early signs of diabetes. If we see some of these signs in patients, we can refer them to endocrine doctors. That's something that I probably don't do as often as I should, and that's something as parents you could ask the doctor, like, are there any side effects that my child is having that might benefit from seeing an endocrine doctor? Are we worried about blood sugar as the weight gain off the chart? Do they have a weight management clinic? Are there people who are thinking about metabolism in different ways than a rheumatologist who might be able to be part of our team and help? And boy, we talked in our focus group today about counseling, and that roid rage is something that's really hard to deal with, and normalizing the fact that if you're on steroids, we give you vitamin D, maybe we should give you a counselor as well, and just not even make it an option, but make it something that's part of the way that we just manage taking these medications. There are certain safety measures that we go through as physicians, I have a little checklist in my brain that I make sure that when patients are taking steroids, we've done things like checked for infections, that we're looking at their cholesterol levels, that we're scanning their bones to check for loss of bone density. In unusual circumstances, nowadays we don't do this very frequently, but some patients who need a lot of IV steroids, we can give them IV access through a port. That's kind of controversial. Many rheumatologists don't feel comfortable doing that because of the risk for infection, but that's something that needs to be figured out depending on the needs of your child. And then the other important thing to talk about is remembering that those adrenal glands that make the steroids are asleep, and in times of stress, it's dangerous because those adrenal glands, say you're in a terrible, God forbid, car accident, you need those adrenal glands to shoot out a bunch of steroids to help protect your body in this time of stress. And if your adrenal glands are asleep, then your child is going to need something called stress dose steroids, which actually sounds like a giant burst of steroids, but it's not as much as they would even be getting for JM. But it's also a different type of steroid to help work that stress reaction. If your child is vomiting, for example, and can't take their steroids for a couple of days, you might start to see signs of steroid withdrawal. And maybe this is something that we don't recognize as well as we should as pediatric rheumatologists, but they might start to be grumpy, they can get fevers, they can have belly pain. It's always important to make sure that you're thinking that we get the steroids refilled, that my child is taking the meds so that we don't go into steroid withdrawal. The best way for us to avoid steroid side effects would be if we didn't have to use steroids at all. And so the medicines we're going to move into now are medicines that help us spare steroids. So we call them steroid-sparing medications. For right now, steroids are still part of our early aggressive treatment of this disease, so it's something that we need to manage as well as we can. And then we have this exciting new formulation that is going to be making its way out that potentially, as we're studying it, we're hoping that will be helpful for kids with JM. So in conclusion, steroids work. I got this slide from Dr. Huber. He said they work, they suck. I call them frenemy, your frenemy. I tell teenagers at first this medicine is your friend because it's actually going to make you feel a heck of a lot better pretty quickly once you start treatment. But as the side effects accumulate over time, it becomes your enemy. But you still can't let go of it. You need to take your steroids. We as doctors and scientists want to use less steroids, and we really want to find medications that allow us not to use steroids potentially at all to treat this illness. All right.
Okay, so we're going to switch to talking about some steroid-sparing agents. In general, like Dr. Curran showed, in the treatment plans and protocols that are generally used by pediatric rheumatologists for juvenile myositis, steroids by mouth or IV or both, and methotrexate are kind of the first-line agents that we use. Hydroxychloroquine or Plaquenil is often like an adjunct or like additional, but it's not thought of something that should be used like first-line or by itself. And there are several other steroid-sparing agents. There are these listed here, and there are even more, but I'm going to go through some, but probably not get to all of them because of time, but we can talk about them on a case-by-case based on your questions. And there are myositis autoantibodies that we're hoping will teach us more about what may be better for certain types of or subsets within juvenile myositis, but we don't know that yet. But that may become more and more helpful in the future. So first with methotrexate, this can be given by mouth or by injection, but like Dr. Curran mentioned, primarily because of like seeing by a rigorous study comparing oral and IV steroids, but in general we know that the vessels are involved with juvenile myositis, that the subcutaneous or injection form of methotrexate likely works better even at the same dose for our juvenile myositis patients. And there are many ways that methotrexate works, and for a lot of our pediatric rheumatology diseases that methotrexate is used for, we don't know like exactly why it seems to help. It was historically used in chemotherapy, so it's more studied in that it decreases the cells that turn over quickly or frequently. So this is just like a complicated slide showing what leads to cell turnover, but methotrexate is in here, so it blocks one of the steps that leads to cell proliferation here. So in general, it's thought to help maybe with decreasing the cells that divide rapidly, which at least one of those types of cells in juvenile myositis are the immune cells, so that's at least one way we think it works. And this medication, like you probably know, is just given once a week, so that's what this calendar is showing. So the most common side effects that are seen in methotrexate are kind of gastrointestinal or abdominal related. You can have abdominal discomfort, which is sometimes kind of nonspecific or described as pain or like a fullness. You can have a loss of appetite, nausea. Sometimes people actually vomit. And then there are people who just generally develop an intolerance. There are some people who kind of develop a reaction around just giving the injection where they like start having pain and nausea even before they get the injection because they kind of have a learned response to it. In general, these side effects can be aided or helped by giving this vitamin or folic acid or folate 1 milligram a day. Some people who prescribe it have you skip it on the day that you get the methotrexate. And oftentimes it's just started at the same time that you start the methotrexate because these side effects are so expected. You can develop oral ulcers, and we think at least partially this is because the cells in your mucosa, they turn over rapidly, so they are more affected by methotrexate. But this is also helped by using the folic acid. And people can have hair loss. It's not usually like you'll have like a patch of hair fall out, but you may have an overall thinning of hair because hair cells are also one of the more rapidly turning over cells. This is just a picture of an oral ulcer. And then another thing we can see, which is not something that a child would feel, but something we know can happen, is an elevation in liver enzymes, which, as you may know, are some of the enzymes that we also monitor for muscle inflammation. So we always monitor these closely. And part of why we give the medication once a week is that's found to be the best way to minimize these liver enzyme elevations versus like giving the same overall dose on a daily basis. And then you can have a decrease in your cell counts, like the cells that are measured in a complete blood count, like the white blood cell count, which is involved with the immune system, and you can also develop an anemia. Oops. So as Dr. Kern mentioned, like in general, for methotrexate and for many of the medications, that's part of why we have scheduled blood draws with your visits to monitor for side effects with the medications. And because we know that methotrexate, at least at some level, is decreasing your immune system function, having an increased susceptibility to infections. This will be a recurring side effect that you'll hear about the medications that I talk about. So there's a potential increased risk for infections. And there really isn't like a standard guideline for how to approach this, but for many people who prescribe methotrexate in pediatric rheumatology, they may have you like not give a dose or two while you're getting an antibiotic when you have an actual infection, just to give your immune system a better chance to fight the infection when you have it. But some may just have you continue it. It may depend on how active your disease is at that time. And then ideally, we would like for you to be completely up to date on vaccines before you start these medications. So you may know, vaccines don't give you an actual infection, but they teach your immune system how to fight potential infections before you encounter them. And there are two different types of vaccines. There's a type of vaccine where you just get a portion of the infection and would never cause a real infection. Those are called like killed vaccines. And then there are some vaccines that are called live vaccines where you do get an actual form of the infection, but it's supposed to be like a low strength or low potency form of the infection. So the live vaccines that are kind of standardly given are mumps, measles, and rubella, and then varicella. Those are part of like standard pediatric vaccines, usually at 1-year-old and 4-year-old. And they, like in a regular healthy immune system, have been tested very broadly to not cause any problems and not cause the infection. But if you were like on this type of medication where your immune system is lower, there's a higher risk that you might actually develop the infection with this live vaccine, even though it's a low version of it. So we don't recommend giving these live vaccines where you're on immunosuppressive medications like methotrexate. And then just as a general measure to try and decrease your risk of an infection, which is probably a good idea for everyone, but just to use good hand washing, particularly when you're in environments where multiple people are sharing things. Like, so for example, at this conference, when you're shaking hands and using common bathrooms, to just wash your hands frequently before you eat, before and after the bathroom. And of course, try and avoid contact with people who you know have an infection. So there are usually contraindications for each medication. For methotrexate, we don't recommend to take it when someone is pregnant because there are known birth defects that can be caused with methotrexate if you're taking it during pregnancy. So it's not ideal for taking during pregnancy. We know it can have negative liver effects, so it's not recommended with chronic liver disease or for people who are consuming a lot of alcohol, which are hopefully not a lot of our, especially younger kids. And if you already have very low blood counts, because we know this can lower your blood counts, it's not like I don't know that there's an absolute cutoff, but if you do have already significant low counts, it would at least be a consideration about not using this medication. Okay, hydroxychloroquine or Plaquenil. This is an oral medication. It is kind of originally developed as in the anti-malarial category. It's weight-based dosing like many of our medications are. And it's like standardly 200 milligrams per tablet, but sometimes it can be titrated by making into a solution, or people like take 1 tablet one day or 2 tablets the next day or something like that. So overall, it's one of the safer medications that we use, but some people can have some gastrointestinal or abdominal side effects like gas, diarrhea, or nausea and vomiting, but it's less common than in methotrexate, for example. Some people have reported having skin darkening in areas or dark spots. They're also called hyperpigmentation, but this is not something that would be associated with pain or not something that you would feel. And there are other nonspecific rashes that have been reported. And in general, for these side effects, they are thought to be generally reversible with reduction of dose, and for many, they may stop on their own even with continuing the medication and not changing the dose. And there There's an association that some people may develop anemia when they're on this medication, particularly if you have this other type of genetic condition, G6PD deficiency. But one big thing we do always talk about with hydroxychloroquine or Plaquenil is that it can have an eye toxicity. This has been studied a lot, and generally for the doses that we use, like 4 to 6 milligrams per kilogram, this is generally thought to be safe for use for like many years, and that's often how it's used in juvenile myositis and for other pediatric rheumatology diseases like in lupus. But we do recommend regular eye exams, not just like a standard optometry exam like you would get to check your vision for glasses, but you would need like a special exam with someone who will check the retina or the back of the eye and like check color vision. And like the eye doctor will know what to check for if it's for Plaquenil screening, but it's more than just checking vision basically. But it's important to do these scheduled exams because this vision loss can happen slowly and it's not associated with any symptoms that the child would recognize. The next medication I'll talk about is intravenous immunoglobulin, or IVIG. So as in the name, this is an infusion. It's given IV. People often use 1 gram to 2 grams per kilogram. And kind of standardly it's given monthly, but as we heard about this morning, it can be given like twice a month, or oftentimes people may split 1 dose into 2 days because it is a large infusion, and sometimes splitting up the infusion may decrease the side effects. I'll talk about it a little bit more. But immunoglobulins in general are kind of are the soldiers of the immune system. Like if you have an infection, your immune system will send out things that kind of look like these Ys to try and coat all of the infection particles in the body and then tell your immune system we need to attack these things and calm them down. But the idea with intravenous immunoglobulin in myositis and other pediatric rheumatology diseases that we use, at least partially, is we think it will, juvenile myositis isn't caused by an infection, but we think it'll calm down whatever's triggering the immune system. So it doesn't actually turn off or turn down the immune system like many of the other medications we use. It kind of just tries to decrease whatever's triggering it. So it's not thought to be immunosuppressive. So that's, I guess, an important distinction. And sometimes it can even help protect you from infections. In general, the side effects that are most common with intravenous immunoglobulin, or IVIG, are headaches and something called aseptic meningitis, where you can have symptoms like you have an infection in the lining around your brain and spinal cord, but it's not a true infection. It's kind of like a little inflammation there that's associated with headaches, and sometimes you can develop nausea and vomiting. And these symptoms are more associated with high doses of IVIG or a rapid infusion. And there's some thought that this might be because you're getting like such a load of fluid, and also it's like a more concentrated fluid that's naturally in your body, and then there are shifts within the compartments in your body, and that leads to some of the side effects. Some people can have fevers or chills or diarrhea and achiness, and there's some people that have described rash and itching, but these 4 are less common than the top 2. And overall, these side effects, they will generally resolve on their own within a couple days, like they're short-lived. And we try to help manage or avoid these side effects by telling our kids and patients to try and make sure they're well hydrated when they come for their infusion. You can always try and slow the rate of infusion, or some people, if they can, like split the infusion into 2 days, either back to back, or do every 2 weeks instead of every month. And then there are certain formats of IVIG that are less like concentrated, so trying to choose a lower glucose or lower sucrose form of an IVIG can be associated with less side effects. And then oftentimes it's given with medications right beforehand to help manage the side effects, like acetaminophen or Tylenol, diphenhydramine or Benadryl, and oftentimes people will get some IV steroids right beforehand as well, either as like a pre-medication just for this or as a separate treatment dose. There has been seen to be anemia or a lower red blood cell count with IVIG, and rarely, and it's more reported in adults, blood clots have been seen. I personally haven't had this experience with blood clots, but it is reported, so I wanted to let you know that. And because of the kind of higher concentration and especially with high sucrose forms, sometimes that can affect the kidneys, so just something to be aware of. But in general, that's monitored closely with the laboratory tests that you get regularly. And again, for these side effects, hydrating well beforehand, trying to avoid more concentrated or sucrose-containing formulations, monitoring laboratory studies, including for kidney functions, which is pretty standardly done with your monitoring labs. And particularly for girls of reproductive age, a lot of birth control pills may include estrogen, which can put you at higher risk for clotting. So maybe avoiding those types of birth control pills because there's a higher risk for clots with IVIG is something that could be considered. There is a rare risk of anaphylaxis with IVIG, particularly if someone has kind of a genetic version of not having this other type of immunoglobulin called IgA. And if you had an anaphylactic reaction, there'd be like, while you're getting an infusion, a rapid fall in blood pressure. But if you've ever been with your child or family member who's getting IVIG or gotten IVIG, you know that they very standardly measure your blood pressure with a high frequency, and this is part of why. So with managing these things, you can ask to check for an IgA level before starting IVIG. Blood pressures are always monitored frequently during infusions. And in general, for anaphylaxis, there are always emergency medicines available with at least your first infusions at the time of infusion. And to be aware, because you're getting this IVIG, it's giving you a bunch of the non-specific immunoglobulins which help you fight infection. If you also got a vaccination while you were getting IVIG, your body may not learn the specific response to the vaccine it would be if you weren't getting the IVIG. So in general, you're getting a non-specific protection from infections by getting this IVIG, but you may not develop the specific vaccination response that you would be if you weren't getting IVIG, so just be aware. A lot of times people will, like I mentioned, it's best to try and get all of your vaccines before you get IVIG. You'll be getting protection in general while you're getting the IVIG, but if you wanted to try and catch up on vaccines, it may be good to try and do those after you're on IVIG to make sure you develop that response. Yes. And then mycophenolate Mofetil, or MMF, it's also called Cellcept. For this medication, it is also something that helps decrease cell turnover at the DNA and RNA level by blocking the pathways that lead to more DNA and RNA replication. And this is also dosed by body surface area. Like in pediatrics, everything's dosed either by weight or body surface area. And there is a different version with a little different dosing called Myfortic, which is an enteric coating, so it's coated to better be processed through the stomach or protect itself in the stomach. Because one of the more common side effects we'll talk about are gastrointestinal or stomach side effects. So upset stomach, nausea, vomiting, and diarrhea are some of the common side effects. So even at the same dose, though, it's thought that maybe dividing that overall daily dose into smaller doses over the day can help with managing those symptoms. So that's something to consider. Other side effects that have been described or can be seen with mycophenolate or MMF are headache, dizziness, difficulty sleeping, and tremor, but they're less common, and some people have described nonspecific rashes as well. And even at the same dose, many of these side effects can go over with time, your body will better tolerate them if you continue taking it at the same dose if you can. Side effects that you can see also with mycophenolate are it can lower your blood cell counts. That's of course not associated with these symptoms, but we'll monitor laboratory tests. And these reliably go away when you stop the medication or lower the medication. And again, this is a medication that decreases your immune system. So you're at increased risk for certain types of infections. So the same sort of recommendations that we would have for other things like methotrexate. If possible, to vaccinate beforehand fully, not give any live vaccines while you're taking this medication, and then generally try and use good hand washing procedures and avoid contact with others with infection if you can. Contraindications with this also include it can cause negative things for pregnancy, for your pregnancy, if you're taking it during pregnancy. So that's a contraindication. And there are many other medications, like I mentioned, but just for the sake of time to give you the chance to ask questions, I'll stop there with specific medications. In general, of course, we'd like to work towards minimizing side effects and better personalizing the medicine for each individual, but we aren't there yet. We're working on it research-wise, but we'll stop here for questions.
We found sometimes that he would have symptoms that kind of mimicked the disease. They weren't sure whether it was caused from the tapering down of the steroids or it was a flare in the disease kind of thing. I mean, without looking at blood work and stuff like that. Is that what they taught? Is that what you kind of talked about when you were talking about the where the steroid disappeared and the other stuff didn't come back in again? Is that where you would see those kind of symptoms? And can you talk to that a little bit? Is this back?
Sorry. So you are asking about symptoms that can happen as steroids are tapered, and the difficulty in trying to figure out, is this related to the disease itself? Is the disease still active underneath, and as the steroids are removed, the inflammation comes back? Or is it a withdrawal effect of the steroid? And that can be really hard to know. Some patients are very sensitive to steroids, so as you taper down, they have side effects like mini rashes or some fatigue, and maybe their muscle enzymes won't go up, but it's enough to make us as a rheumatologist wonder if it might be a little sign of flare. Arthralgias, like pains of joints, are possible. I mean, I think it's quite hard to distinguish. It is possible to measure your body's level of cortisol, and that has to be done in the morning. Our body naturally makes steroids in the morning. So if the adrenal glands are very suppressed, that early morning cortisol level will be too low, and that's a signal that we need to change the way we're tapering the steroids. So that's one way to look at it a little bit scientifically. It's not an easy answer. I think what I've found from practicing is that some patients tolerate a taper very well, and you can go faster, and others need a very, very slow taper. Yeah. My guess is that this is a very broad generalization, but if you feel bad after going down on a steroid taper, it's more likely to be the steroid effect than the disease just waking up that day, because it does take a little time for the disease. So it might be more steroid related, but it's hard to say. Mm-hmm. Yeah, I've had some patients who really require maybe going one day 8, one day 7, one day 8, one day 7 for a little bit, for like a week or two before you go down from 8 to 7. Yeah.
I don't know if I have anything to add. I think it's very individualized, but we do see a lot of people where the person or the child really knows their body well, and they can feel something. So that's, I think, where what you as a family members and the child knows can discuss with your doctor what you think might work well. Sometimes doing a very slow taper like that and is just how you'll learn how that child may better tolerate the taper.
I have a question on steroids and growth. I know that was one of the side effects that you had up there, and I was just curious, when they're off the steroid, does it reverse? Will they make up for that time? I don't want to be too specific, but our daughter's she's very small. She was on steroids for about a year, but she's tiny for her age. And I just don't know if that's just her makeup and the way she's going to be, or if the steroids kind of stopped that growth, and that's where we're going to land.
Yeah. So the question is about steroids and the effect on growth, and particularly like height you're talking about, or even weight as well. Just she's a
She never gained weight even on steroids. That makes me feel guilty because I know so many kids battle that.
yeah, I've seen that in some patients, especially younger kids, and possibly ones who are more rashy, who probably had more issues with their blood vessels being inflamed and might not have absorbed the steroids quite as well. So the teaching, well, first of all, you have to separate out is any type of growth suppression related to the disease itself versus the steroids. So the inflammation, you can think of it as your body is making inflammation. It's spending a lot of energy and calories on making inflammation and doesn't focus as much on growth. So actually, inflammatory diseases can stunt growth. Steroids themselves can suppress growth as well. I would say for most of the patients who I've had on steroids long term, as they're growing their growth chart, we follow that. We should be looking at that every appointment or so. They may slow down a little bit, but in terms of linear growth, most of my patients tend to catch up. The ones who fall off the growth curve may not be getting enough nutrients for various reasons. Their disease may still be active. So I think the effect of the steroids themselves, it goes away after the steroids are withdrawn for the most part.
No, I agree. I think it goes like basically if you get to a point where the disease is well controlled, so that inflammation is not taking up the body's energy from growing and the steroids are not there, then the kids will reliably catch up to where they would be genetically, is our experience.
She also had a lot of inflammation in the stomach when we did with the endoscopies for a few years. So I think that goes along with, I didn't realize.
Yeah, she might not be absorbing.
Right.
Absorbing.
Yeah.
Hey there. Our daughter has had a tough year. She's in full unmedicated remission. She did just the Methotrexate and the Prednisolone in a 2-year thing, and has, as far as disease activity, has been fortunate after that. But one of the things that happened to us, and I have to tell this story to ask this question, she had seemed to have chronic long-term sinus infections every winter for several years, and we kind of pursued that through our pediatrician first, and generally kind of went with long-term antibiotics until it happened so much. We finally ended up getting a surgery and routed through to an immunologist who did a blood screen, and we found that there were 2 things that she had 0 resistance to, and one of which was mold. And so in
The antibody that would protect you against sinus infections and pneumonia. I can't remember what it's called. Strep pneumonia. Yeah, there were 2 boosters that they ended up giving her.
Yep. And thank you, yes. So they gave her boosters in that, and 30 days later her blood was good to go. So what I'm wondering is, do we know, because no one could tell us for sure, do the panel of immunizations you get survive the process of the treatment for JM? And can we make it standard that we just check after we're done? Because it's so easy. We're already taking blood anyway. We check it. In her case, we could have avoided years of infections and antibiotic use, and we could have avoided a surgery. Did you want to?
I'm just saying possibly and hopefully. I mean, you can't.
Yeah, that's a really, really good.
Right.
Same story. Same story.
I'm not sure if we know if there is like an ideal panel of blood tests to check for everyone, to see what susceptibility to infections they have. I mean, like you all know, there's a standard regimen of vaccines, and it's just based on age, but that vaccine is for kids that are healthy, of course, and that grow up healthy. So we don't know exactly what's the best panel to check in people who develop JM, and then they probably don't have time to develop all the vaccines to do that set of vaccines when we already see them inactive and we need to start the medications right away. So that's part of the problem. But that's definitely a good point. Infections are something that we're always worried about, particularly with the medications that we use, and it's hard to kind of look back before they were sick to know what we could have done before, because we usually get involved when we're ready to treat and we don't have time to do that sort of evaluation. But it's definitely something we should look into further. It's an important point.
I think maybe what he missed is she was vaccinated. She was old enough that she was, yeah. So So maybe I'm just misunderstanding, because I think it's our pediatrician said, oh, gosh, kids that have methotrexate that are treated for cancer, they screen them. If we had screened her, we probably wouldn't have gone through all this. And we were like, so I don't know if that was accurate, but of course as a parent we're like, really?
Well, I can speak to it for sure. So we're using the mic so the recording can pick it up. So there are practice differences in the way that rheumatologists work. And for example, some of the doctors I work with are trained as immunologists as well. And some of us will check a panel of antibodies to see if you responded to your vaccines in the beginning. It is common for vaccine immunity to wane over time or to go down. So I think if we checked many of us in this room, we might not have a great response anymore to those infections, but we're older and we're not going to be exposed to them as much. But if it wasn't done in the beginning, I wouldn't say it's bad medicine. I think it's just difference in practice, but it is something for us to be aware of. But when a patient does start to get a lot of infections, that's something that we would think about. Yeah, it's a red flag to say, is it time to do a little more of an immune evaluation? And what Dr. Kim was talking about, when patients get IVIG, they're actually getting antibodies from immunized healthy people. So that helps to protect them. It doesn't sound like your daughter needed IVIG, but that can also kind of confuse the picture because you don't know, is it your for them from theirs? So sometimes, like before we start IVIG, there should be a panel of things that we think about. Should we check their vaccine response before we give them IVIG because maybe they didn't respond well themselves, and that's something we need to keep in mind. Sure.
So the P155 antibody, I believe, is the one that can possibly predict like a more chronic, kind of like a roller coaster course. Is there, this is just kind of a curiosity question, is there like a consensus of these kids that we know that are going to most likely show flares more than kids who don't have this antibody? Is there a consensus of when you would go back to steroids if the child was weaned off of steroids? Or like if a child, like my child, for instance, has shown signs of flare twice that were minimal, skin-only involvement. So I'm just wondering if there's ever a point where they would actually go back to steroids. And I know it's a loaded question. It would be different for every kid, but if there was just like a general consensus, like rheumatologists are going to consider in general going back to steroids when you hit this point.
I think that a lot of it depends on how sick the kid is. So for example, I have had patients who have been kind of lost to follow-up, or they were doing well and they got sick at home and there was some denial and different things happened and they came to us and it's like, oh, this is an obvious flare. You need that punch right in the beginning. You need some steroids. Probably the people in this room will be coming to see the rheumatologist on a very regular basis, and we're going to be checking labs and checking minor skin flares, and we love to avoid steroids if we can. So, it's an easy answer on the obvious ends. It's then that middle ground that we all struggle with, and there's not a consensus for when steroids need to be restarted other than like it's an obvious flare and you want to get something on fast. And I have had some patients who have flared, and the minute we talk about this is a flare, just the faces in the room are like, we don't want to go on steroids again. What are we going to do? So I've had some patients we managed with IVIG. I've had some patients where I said, I'm going to put you on a 2-week dose of steroids. I promise we're going to take you off and we'll see what happens, but I'm not going to commit you to a long course of steroids again. Like, we would want to avoid that as much as possible. And that's also when we reevaluate our steroid sparing meds. So say a kid is flared, they're on metho, the steroids are tapered away, they have a little bit of a flare. Are they on the best dose? Do we optimize it? Did they grow? Do we need to change their dose? Can we add something else so we don't have to add steroids? That's my bias because I feel like steroids are tough, but then I also struggle sometimes saying, I did as much as I could to try to help this kid avoid steroids. Was I wrong? Did they just need a bunch of steroids? And there's not a good answer. And there aren't blood tests that can tell us whether or not.
I was just going to say, just for your question about the myositis-specific antibodies, unfortunately, we don't have good plans for like this antibody. Like, if this happens, you should do this. If this antibody, do that. We're not there yet, but we're hoping to learn more about that. Like, we're starting to get a sense. Like, Dr. Curran and myself and Dr. Ryder and all of the people that you heard from this morning, we're starting to already kind of know the flavors within those groups and kind of have a better idea of what may sort of to expect within those groups, but it's not exact, so we don't have consensus treatment plans for those things yet, unfortunately. But we're hoping to get there. Okay.
Oh.
Okay. Yeah, we'll come back. So this is an online question. Should you or shouldn't you take folic acid the same day you give methotrexate shot?
I think it's a style difference. I've worked with different people. We're trained in different places. I think for some people it's just easier to be consistent, and it's hard to remember do one thing on one day, one thing on a different day. And there are some people that feel like you shouldn't take the folic acid maybe on the day you're getting methotrexate because you want to get the most effect of the methotrexate on that day, and the other days taking the folic acid will help protect you from the side effects. But I don't think we have any studies to prove either way. Okay, good.
Yeah.
I think people practice both ways, and it may just depend on your child how well it works.
Yeah, it's a good question, and it's something that people are like. That's something that's like, what we don't want to take a ton of time to study something like that. So those kind of things we just don't have great answers to. But I did find a study in, I think it was in rheumatoid arthritis, so it can't be, directly to JDM, but they basically looked at patients who had done their folic acid every single day and those who had skipped a day, and they didn't see any differences. Like the ones who did 6 days a week weren't flaring more. So it was like not a... They did not have more side effects either. So if you take it every 7 days, it didn't seem that those patients were having more side effects. But it's probably a relation to just the way that your doctors were trained.
So for those of us who have kids who have been sick for a long time, and we're coming to the understanding that they're probably going to need to be on, and we need to wean down at some point, we'll be ready to wean down. And we understand that we probably need to be on a maintenance dose of something for years and years and years and years and years. Thoughts on the best medication to be on for like extended periods of time?
So I think the quick answer is if there is one medicine that seems to have worked well for your child, that might be the best medicine for him or her. Like I have had a few patients who were on both methotrexate and Cellcept, and they're doing well, and it's time to go off one, and there's not a right answer. Like when we added Cellcept, it was a big difference, so then we just maintain that patient on Cellcept. Right now, we don't have an understanding, personalized medicine, like this medicine is going to work best for you because you have these antibodies or this genetic change. You also have to factor in things like intolerance of medication over time. If they hate methotrexate and they're not taking it and they're hiding it, then that's obviously not the best medicine to take. And you have to take into consideration things like if a patient wants to get pregnant in the future, then you have to find medicines at the time of pregnancy. It's fine to take methotrexate and Cellcept. It doesn't cause damage to fertility or damage to eggs or sperm, but it's just at the time of the development of the fetus.
I'm having trouble reading this one. When your JMer has experienced side effects of Plaquenil, specifically...
Autocorrect problem.
Yeah, Regina issues and plaque.
Retinol.
Retinol, good one.
Vagina. Okay, I'm glad it's not vagina.
I thought that, but I'm like, I don't know.
And plaque, it has been DC. What does that mean?
And
discussed?
if Plaquenil has been
discontinued.
Because of should Plaquenil not be used again? Okay, I get it.
Okay.
Yep. So the question is, it sounds like that this person's child had retinal problems on Plaquenil, and so Plaquenil was stopped. And I think the question is it dangerous to restart Plaquenil? So, I think we'd work closely with the eye doctor. Yeah, I think the first question is to figure out, is it truly a side effect of the Plaquenil? Because there are certain side effects that we would say, no, we do not want to continue because the retina has accumulated a little bit of damage and we wouldn't want to go back on Plaquenil. There are other medications kind of in the family of Plaquenil that could be considered, but they often have other side effects as well, so we don't use those as much. So I think it depends on exactly what's going on with the eye. And then if it was felt like it was a really great medicine for the patient, it could be started possibly at a low dose and the eyes watched very, very closely. Yeah.
You had mentioned flow cytometry test or whatever. What is that, and where would it be applied within the,
So in some centers, and depending on the medications that the patients have taken, we'll do a test called flow cytometry, which basically takes your white blood cells, a certain type of white blood cell called lymphocytes. And that was the diagram where I showed kind of branching off. And then it separates the lymphocytes into the different types of lymphocytes, which are B cells, T helper cells, cytotoxic T cells, natural killer cells. If a patient has received rituximab, for example, rituximab is going to get rid of your B cells or your CD1920 cells. So we would follow that. We would do flow cytometry to look and see if the B cells are gone and when they start to come back. In some centers, more research centers, they'll do flow cytometry to watch the different types of cells over time. Some patients are thought possibly to have an increase in B cells at times of flare. Some patients might have a decrease in natural killer cells at times of flare. This isn't well studied yet. There are a few studies that have been published, but it's not standard of care for rheumatologists to all get flow cytometry. It's also a very expensive test. So certain situations it's used. Yeah.
What's the best way, in your opinion, to wean off of IVIG? Because we're just starting that process, and then today during the session there were literally exact thoughts, and our doctor has literally next month is going to go down to 5 weeks, and now I'm freaking out because it's the summer and that's what we're doing. So I was just wondering, is there like a protocol, or is it really just doctor practice, which is what I feel like I've heard a lot in general.
No, it's, you know what, when Dr. Ryder said that this morning, I was like, oh, that's what I'm going to do from now on. So there isn't a protocol. So when she said the half-life is 30 days, that means the burst of IVIG you got on day 1, at day 30, half of that should be out of your system. The antibodies die about 30 days. And another 30 days, another half of that is gone. So her theory is that if you want as much of that in your bloodstream as you can have, so it makes more sense instead of spacing out to reduce the dose time by time. It's really, the other thing that we know is that the amount of IVIG you get kind of changes the way that the immune system is modulated. So when you're giving at 2 grams for every kilogram, if you go down to 1 gram for every kilogram or half a gram for every kilogram, then it might be working differently that way too. So there's not a right answer. I think a lot of us space it out. Do you?
I think people
do it totally differently. So we in my center tend to space it out. And then if a kid flares or feels terrible after week 6, then we'll go every 6 weeks or every 5 weeks. My thought is maybe a little more from the practical side of things. Like if we can get you to the infusion center less frequently and your kid is still doing well, then that's a good thing. But yeah, so it's either reduce the frequency or reduce the dose. And sometimes I've done a little bit of both. So no right answer.
I think also sometimes for people who space it out like that, they want to see if you can tolerate it in like longer frequencies, because sometimes people, they may not, match the book published 30-day half-life. You may have a longer half-life. And sometimes for many kids that we see, they kind of, or your parents and family members can see like, oh, they seem like they're a little bit more tired when they're due, or they have a little bit more rash when they're due, and they may show you how frequently they need it. So that you may only see by trying to space it out further.
Yeah. Maybe that's a patient who you wouldn't taper because it's a sign that the medicine is helping to keep the disease activity suppressed, or possibly you could go down on the dose a little bit and see what happened.
Just a comment on that. Don't you normally do some blood testing, check the enzyme levels as well when you start reducing the IVIG?
Yeah. So the comment is, are you checking to see if there's biomarkers of flare that would help you know whether it's good or a good time to start reducing medications? Yeah, I mean, you rheumatologists, we love blood, right? We draw blood every month. We look at all these numbers to try to understand for every patient. Every patient's a little bit different. So I have some patients who bump up their LDH when the child is starting to flare. I have other kids who bump up neopterin or other markers in the blood. So if markers are going up, then that's probably not a time to change. But the other thing that's very frustrating is sometimes the medications can be keeping the markers quiet, but there are other things, and that's why we spend a lot of time talking to you and trying to understand if they're and looking at the skin. So maybe blood is going to stay completely normal, but an obvious rash is developing. Then that's another way that we look to see, is it a flare? Is it time safe to reduce medicines?
Basically, it's just like a question about all of our children take these medicines for years and years, and like I know one of my things that I always think about is like, what is, you're controlling the JDM, but what is the medicine doing to, like, long term going to do to our children? I don't know if the studies have been done long enough to know that, or if there has been. Like, my daughter's on Cellcept. A couple of years, she's on it for a couple more years. What's that going to do to her body?
It's a really hard question, and it's something that I think as physicians we might not show it, but we do think about this a lot, and we're always juggling the risks of the disease being not treated well enough and causing damage to the body versus the risks of the medications. We really don't have a lot of information on long-term medications, and it's really hard to sift out. Even if we had, all the data we needed in patients for 50 years, every single patient, it would still be really hard to sift out what would be an effect of one medication versus another. What is the fact that the patient's disease, wasn't well controlled on that medication possibly. So it's really hard to know. I think we probably can infer from long-term studies of patients who have received organ transplants, for example, because they receive sometimes the exact same medication, Cellcept, and understanding kind of what's happened to those patients over time. So we do think that there is a small increased risk of developing cancers over time in patients who have had long-term immunosuppression. There's also, but we can't tell you exactly what risk, exactly what kind of cancer, and then it also factors in your, genetic makeup and exposures and things like that. But we do know the risks of not treating our disease well enough, and that's where the rheumatologists get scared, because we see the kids who haven't been treated well, and we know the bad things that can happen to them. So we always wonder, are we over-treating? Are we under-treating? Are we causing more bad side effects from drug over time? Sometimes it's very obvious and the med needs to be stopped. But I would say if a patient is stable and doing well and being monitored on a regular basis, so we can check things like liver function, kidney function, and blood cell counts, if your child and your daughter is doing well and stable on those medicines, I would say overall it's probably safe and a good thing for her.
I would say in general also, you may know that there probably is something that's a little different about someone's immune system to begin with, that they got juvenile myositis. So even though there are studies that may say on this medication, like more of the biologic medications, they've studied that there is a little bit higher risk of cancer. It's many pediatric rheumatologists think, and I think in general we've seen just by having that autoimmune disease or rheumatologic disease that already puts you at a higher risk for cancer, so it's less likely because of the medication, but we can't guarantee that because there's not really a good way, and there haven't been studies to prove that. Like Dr. Curran was saying, I think 100% of the pediatric rheumatologists would always use whatever medications they thought would work best to treat the disease, even though we don't have good information on long-term use. For the pluses and minuses, unfortunately, we don't have any juvenile myositis medications that have really been developed just for juvenile myositis. So that's a negative, I guess, but it's not really targeted for our disease. But the plus is that it's been studied in another disease, maybe in a different dose, in pediatric populations, even though it's not exactly juvenile myositis. And at least there's enough information that we think it's safe enough to use longer term from those diseases that we feel comfortable using it.
I was just interested in the medication rituximab. That's like a third line, right? Yeah, were going back and forth with my son with that, and actually they increased his methotrexate. They realized he wasn't on a full dose of methotrexate, so they went up on that, and I'm hoping that holds. But the side effects from that.
You have a slide? Do you want to? You can talk. Okay. So the question is about rituximab. So rituximab is a medication that actually kills off a specific population of white blood cells called B cells. And B cells are the one, if you remember on the little diagram, they're the ones that eventually will morph into cells that make antibodies. So the idea behind rituximab is if you get rid of B cells, you're not going to be producing as many bad antibodies as time goes on. B cells also have other functions. They talk to other immune cells like T cells, and when they do that crosstalk with each other, that can stimulate the immune system. So if you get rid of B cells, that can have an effect of just less stimulation on the immune system. So there has been a study that Dr. Reed talked about called the rituximab in myositis study, the RIM trial. That was the graph that you saw today, where the kind of the stair step down of how long patients how better patients got over time. So what we saw in that trial is that the juvenile patients who received rituximab got better over time, and they actually did better than the adult patients who got rituximab. She was showing some slides where they separated out if your child has a certain autoantibody related to myositis. Some patients with certain antibodies were better responders to rituximab. If your kid had an antibody that wasn't a good responder or doesn't have an identified antibody, sometimes we still consider using rituximab because there's reasons that it works that aren't just related to the antibodies themselves. So the side effects from rituximab, so the main thing with all of our drugs is immunosuppression. So if you don't have B cells, you are probably a little more at risk for getting infections. Rituximab is an infusion that you receive once. There's a couple ways to give it. Most people nowadays are doing, you give it once, and then 2 weeks later you give it again as an infusion, both their IV, and then you don't give it again. You watch over many months. By about 6 months, so right away you should see B cell numbers decline. So in the flow cytometry, the B cells should go down. If they don't go down, then your patient is not a good responder to rituximab, so that might not be a good medicine to use over time, but almost always they go down to 0. And then over the next many months, they will start to repopulate. Most patients repopulate by 6 months. Some patients don't repopulate for years. So that's a reason for us to kind of watch and see what's happening. Some patients, when they repopulate, they flare. The antibodies start to be produced again. And so then you can redose rituximab over and over again as a maintenance medication. Some patients will have an infusion reaction to rituximab. It happens in about 30% of patients who get it for the very first time. So things like flushing and itching, fever, chills, flu-like symptoms, and it can be scary because it mimics symptoms of anaphylaxis or like a bad allergic reaction, but most of the time it's actually not an allergic reaction. So if we slow down the rate, we would usually stop it, give some meds to recover, return to the medicine, turn it back on at a slower rate, and many patients tolerate it that way. But I've learned to warn people about it because it can be scary. The pre-medications are helpful. And then we monitor lab tests over time just to make sure if the white blood cell count goes way too low, then rituximab might also not be a good medication. Does that answer your question? Yeah, you know, because it's an antibody medication, it doesn't cause things like toxicity to organs like we talk about with methotrexate. Some of these medicines like Cellcept and methotrexate work differently, so they can cause dysfunction of organs. Rituximab really hasn't shown that over time. Things like headache, nausea, vomiting around the time of infusion, but then once the medicine is stopped, usually not anything significant. Have you had different experience?
No, I think this slide just mentions we check everyone for hepatitis B, and yeah. I think we just take a little bit more caution also because this is like a longer lasting medication. It's not like we can just stop it like after we've given it like some of the other medications we give daily or weekly. So we just are thoughtful when we give it because it's going to last for months at least.
Yeah, that's a good point. When you take away those B cells, you can't put them back in. So then you have the effect for a longer period of time. It's literally like the question is, how do you determine, oh, this is a good medication for my child. She didn't have side effects. It seems to be working. How do you know which is a good medicine for your patient? A lot of it is just observation. Yeah.
Yeah, that's like definitely $1 million question that like researchers are really trying to work towards. Part of like what you've heard about many times is, you know, they've showed like how variable it is in pediatric rheumatology practice it was to begin with. So we're trying to get to a point where we're all starting at the same place so we can learn more about what differences between people help us determine what medications are for which person better. But it is something we're working on.
Yeah. You're welcome.